Hi and assalamu alaikum everyone. My name is Soraya BINTI ZAINAL AZMAN from class HS2622A. Today, I will be presenting about the lateral knee projection. In this presentation, I will talk about the radiography anatomy of the lateral knee, the positioning criteria and also the exposure factor criteria. And most importantly, I will evaluate the radiograph of the lateral knee projection based on the AZMAN method to see whether the radiograph reached the good criteria for good image quality, and to see whether the radiograph is acceptable or rejected. Now, let us get started with the presentation. So first, what exactly is a lateral knee projection? It's a radiographic view of the knee taken from the side. The X-ray beam travels from the medial side to the lateral side, with the lateral part of the knee closest to the image receptor. This view is essential for visualizing the alignment, joint space, and bony structures of the knee. Before we look at the image, let's understand the anatomical structures of the knee. Firstly, we have the femur. It is the long thigh bone, and it is seen at the superior part of the radiograph. Femur ends in two rounded structures, which are the lateral and the medial epicondyles. Next, we have the lateral and the medial epicondyles. It is the rounded end of the femur. In a true lateral knee projection, the lateral and the medial epicondyles should be seen superimposed with each other. And these condyles form the upper part of the knee joint. Moving on, we have the patella. It is the triangular bone located in front of the femur. In a true lateral knee projection, patella should lie over the femoral condyles, with its articular surface facing them. Next, we have the tibia. It is the shin bone located below the femur. It supports the femur and forms the lower part of the knee joint. And the flat upper surface of the tibia is called the tibia plateau. Then, we have the fibula, which is the smaller bone beside the tibia. It is not directly involved in the knee joint, because it does not articulate with the femur directly. It is located posterior to the tibia on true lateral view. Lastly, the key joints seen in true knee lateral projection is, first, the patellofemoral joint. This joint is located between the patella and the femur. Second is the tibiofemoral joint, which is located between the tibia and the femur. Now, let us take a more closer look of the anatomical structure of the knee. So, firstly we have the patella, which is located proximal to the patellar surface of the femur. Then, we have the patellofemoral joint. This joint should be seen open to ensure the medial and lateral epicondyles are superimposed with each other. Next, the anterior and the posterior of the medial and lateral epicondyles should be aligned to ensure they are superimposed. Next, the proximal tibia should be superimposed with one half of the proximal fibular head. And lastly, 1/4 distal of femur and 1/4 of the proximal tibia and fibula are included in the collimated area. Now, moving on to the positioning criteria to obtain good quality of the radiograph. Firstly, the affected knee should be flexed 10 to 15 degrees. This is to ensure the patellofemoral joint is open, and the medial and lateral epicondyles are superimposed. Then, the patella. It should be situated at the patellar surface of the femur. Next, the patellofemoral joint and the femorotibial joint should be open, to ensure the knee is in true lateral position, without any rotation. Then, the lateral and medial epicondyles should be seen superimposed with each other. Last but not least, the proximal head of fibula should be slightly superimposed with the proximal tibia, to show correct rotation. Now, let us look at the radiograph of lateral knee that shows incorrect positioning. Firstly, this position of radiograph lateral knee shows the knee is under rotate. This is because the lateral condyle appears posterior to the medial condyle, and the fibular head appears to be too anterior. Second radiograph of this lateral knee shows the knee is over rotate. I say so because the medial epicondyle appears to be more posterior to the lateral condyle, and the fibular head appears too posterior. The third radiograph shows the knee is underflexed. When knee is underflexed, the knee will appear nearly extended. The patella is positioned high, and the patellofemoral joint space not clearly visible. The last radiograph shows the knee is overflexed. In overflexed knee, this means the knee will bend too much. The patella will pull downward and they are very close to the femur. And lastly, the patellofemoral appears narrow or even closed. Moving on to the exposure factor criteria. The ideal exposure factors are between 65 to 75 kVp and 4 to 8 MAS. In terms of contrast, the thin structure is bony cortical outline of the patella. And for the thick structure, it is bony cortical outline of the femoral condyles. Now, in terms of density, the thin structure is bony trabeculae pattern of the patella. And the thick structure is the bony trabeculae pattern of the femoral condyles. First, let us see how to evaluate the radiographic contrast. We must assess the bony cortical outline for both the thin structure and the thick structure, which are the patella for thin structure and the femoral condyle for thick structure. Then, we must identify whether the kVp used is adequate, not adequate or too much. Then, we have to give suggestion on what action to be taken to improve the image quality. Firstly, if both of the bony cortical outline of the thin structure, which is the patella, and the thick structure, which is the femoral condyles are visualized. Therefore, the penetration, or the kVp used, for the radiograph is adequate. No changes need to be done to the kVp. However, if the bony cortical outline for the thin structure, which is the patella is visualized, and the bony cortical outline of the thick structure which is the femoral condyle is not visualized, then, it means, the penetration, or the kVp used for the radiograph is inadequate. Therefore, in this case, the kVp must increase by 15%, and the MAS must be reduced by half, to maintain the original density. Now, if the bony cortical outline of the thin structure which is the patella is not visualized, and the bony cortical outline of the thick structure, which is the femoral condyle is visualized, it means that the penetration and the kVp used for the radiograph is too much. Therefore, the kVp must be decreased by 15%, and the MAS should be doubled in order to maintain the original density. And, lastly, if both of the bony cortical outline of the thin structure, which is the patella, and the thick structure, which is the femoral condyles, are not visualized, it also means that the penetration or kVp used for the radiograph is too much. Therefore, the kVp used must decrease by 15%. Now, in terms of the image density, we will assess the MAS used. Firstly, if both of the bony trabecular pattern of the thin structure which is the patella, and the thick structure which is the femoral condyles, are visualized. Therefore, the MAS used for the radiograph is adequate. No changes need to be done on the MAS. Next, if the bony trabecular pattern of the thin structure, which is the patella is visualized, but the thick structure, which is the femoral condyle is not visualized, then, it means, the MAS used for the radiograph is inadequate. Therefore, action should be taken is, increase the kVp by 15%, and maintain the MAS used to avoid overexposure of the image. Next, if the bony trabecular pattern of the thin structure, which is the patella, is not visualized, but the thick structure, which is the femoral condyle, is visualized, it means that the MAS used is too much. The radiograph is overexposed. Therefore, the kVp should be decreased by 15%, and the MAS should be maintained. And, last but not least, if both of bony trabecular pattern for thin structure and the thick structure is not visualized, it means that the MAS used is also too much. The radiograph is overexposed. Therefore, action that should be taken is, reduce the kVp by 15%, and reduce the MAS by 50%, to improve the image contrast and preventing overexposure. Here is an example of radiograph of the lateral knee projection with incorrect exposure factor. This is because, in both images, the bony cortical outline and the bony trabeculae pattern of the patella is not visualized. Now, I also provide an example of radiograph of the lateral knee projection with correct exposure factor. As you can see, in this radiograph, both of the bony cortical outline and bony trabeculae pattern of the patella can be seen. Other than that, both of the bony cortical outline and the bony trabeculae pattern of the femoral condyles can also be seen. Now, I will be evaluating this radiograph of the lateral knee projection using the Paceman method, which are P stands for projection and positioning, A stands for alignment, C is for collimation, E is for exposure factor, M stands for marker, another A is stand for aesthetic, and, lastly, N stands for name and patient's info. So, do you think this radiograph of the lateral knee projection shows correct positioning? Exactly. Let me evaluate this radiograph. First of all, this is the radiograph of a lateral projection of the knee. I say so because the lateral and medial epicondyles of the femur are seen partially superimposed with each other. Although, in true lateral knee projection, the lateral and medial epicondyles of the femur should be seen superimposed with each other. Next, I also say so because in this radiograph, the patella is seen from the side, not from the front view. This means the image was taken in a lateral projection, which is correct. A postero-anterior view would show the patella from the front, but for this projection, we need to see it clearly from the side to assess the joint space and alignment properly. Now, let us look closely at the positioning of this radiograph. If we look closely at the medial and lateral epicondyles, they are not superimposed with each other. The medial condyles are posterior to the lateral condyles. This indicates rotation of the knee, which is, the knee is in external rotation. To improve this, rotate the patient's knee internally until the lateral and the medial epicondyles are superimposed to each other. Secondly, the patella is not in full profile. The patella is not in true lateral view. The patella is situated too high and far from the femur. This indicates the knee is underflexed. To improve this, increase the flexion of the knee by bending the knee more until the patella move into the trochlear groove to ensure the patella is in true lateral position. And lastly, the tibiofemoral joint space is not fully visible. This indicates rotation because the lateral and the medial epicondyles are not superimposed to each other, causing the tibiofemoral joint space to be overlapped by the femoral condyles. To improve this, slightly rotate the patient's knee until the lateral and medial epicondyles are superimposed. Let's move on to the alignment of this radiograph. First of all, let's take a look at the alignment between X-ray tube and cassette. To determine the alignment between X-ray tube and cassette, we must evaluate the distance between the edges of collimation and edges of film. Based on this radiograph, the alignment between X-ray tube and cassette cannot be determined. It is because there are no presence of all four borders of collimation in the radiograph. Secondly, we must also evaluate the alignment between X-ray tube and patient. To evaluate this, we must compare the distance between edges of collimation and central structure. Based on this radiograph, the alignment between X-ray tube and patient cannot be determined. It is because there are no presence of four borders of collimation in this radiograph. And, last but not least, we must also evaluate the alignment between patient and cassette. To evaluate this, we must compare the distance between edges of film and central structure. Based on this radiograph, the alignment between patient and cassette is incorrect. It is because the distance between the edges of film and the central structure is not equal laterally. Since there are no presence of four borders of collimation in this radiograph, so the centering point for this radiograph cannot be determined. And the standard centering point for this projection is centered to 1 inch distal to the medial epicondyle, and the central ray is angled 5 to 7 degrees cephalad. In terms of collimation should be done to all four borders of the film, and should include superior border, lateral border and also inferior border. Collimation is very important because it helps reduce radiation exposure to the patient by limiting the X-ray beam to only the area we need. It also improves image quality by reducing scatter radiation, which gives us better contrast. Firstly, let us look at the superior border. At the superior border, structures that should be included are shaft of the femur, and, lastly, the epicondyle of femur. Next, let us look at the lateral border. At the lateral border, structures that should be included are the patellofemoral joint, the patella, and, lastly, the fibular head. Last but not least, let us look at the inferior border of the radiograph. At the inferior border, structures that should be included are the fibula, the tibia, and, lastly, the tibia plateau. Other than structures that should be included at all four borders of the radiograph, we should also identify whether there are presence of radiation protection apparatus in the radiograph. Based on this radiograph, there is no evidence of radiation protection apparatus seen on the radiograph. Now, let us move on to the exposure factor given on this radiograph. When evaluating the exposure factor, we must look at the KVP and the MAS used. The KVP used gives effect to the contrast of the image, while the MAS used gives effect to the density of the image. To ensure if the exposure factor is appropriate, we must assess the image using the structures for bony cortical outline and the bony trabeculae pattern. We must also assess whether the thin structure and the thick structure are visualized in the radiograph. In knee lateral projection, the thin structure is the patella, while the thick structure is the femoral condyle. Now, let us evaluate the exposure factor of this radiograph. In terms of the radiographic contrast and the penetration, we can see that the bony cortical outline for the thin structure, which is the patella, can be seen. And the bony cortical outline for the thick structure, which is the femoral condyle, can also be seen. Therefore, the KVP used for this radiograph is adequate for penetration and the radiographic contrast. Now, in terms of the density of the image, the bony trabecular pattern for the thin structure, which is the patella, can be seen. And the bony trabecular pattern for the thick structure, which is the femoral condyle, can also be seen. Therefore, the MAS used for this radiograph is adequate for image density and detail. Therefore, no changes need to be done on both KVP and MAS because they are already suitable. The exposure factor used in this radiograph is appropriate because both of the bony cortical outline and the bony trabecular pattern are visualized. Now, let us move on to the marker part. Using a marker is a standard practice for radiography to indicate the correct side, whether it is the left side or the right side. This can help to avoid confusion during diagnosis. Other than that, marker also should be placed outside the region of interest to avoid medical errors. Now, let us evaluate the usage of marker in this radiograph. Based on this radiograph, there is evidence of an anatomical marker, which is shown in the radiograph. The marker is placed at the right side of the radiograph. And it is placed appropriately, and, most importantly, the marker is not superimposing with any region of interest. Next, let us look at the aesthetic quality of the radiograph. Aesthetic refers to how clean, clear, and professional the image looks overall. In this part, we will assess the film size and the presence of any artifacts in the radiograph. It is important for the radiograph to be free from any artifacts, so it is easier for the radiologists to focus on the anatomy and make an accurate diagnosis. Now, let us evaluate the aesthetic of this radiograph. Firstly, the film size used is 24 by 30 centimeters, which is appropriate because it includes all the structures of interest without cutting off any important structures. Secondly, there is no evidence of any visible artifacts in this radiograph. Finally, let us move on to the last part, which is the patient's name and patient's info. This part is very important because every radiograph must include the patient's name, ID number, date of examination, place of examination, and the radiographer's name. These details help to make sure the image belongs to the correct patient and is properly documented. If any of this information is missing, the radiograph can be considered incomplete or invalid, especially for medical records or legal purposes. Let us evaluate whether this radiograph contains all those information. Based on this radiograph, there is no visible patient information. Details, such as the patient's name, ID number, date of examination, place of examination, and the radiographer's name are all not visualized. These information should be placed at an appropriate area in the radiograph, which does not superimposing with any structures of interest. In conclusion, this radiograph is not acceptable. It is because the knee is in incorrect positioning. There is clearly rotation of the knee. And the patient's information is missing. There is no patient's name, ID number, place of examination, date of examination and the radiographer's name. That is all from me. I hope all of you enjoy this video. Thank you.